So everyone, we have met Abby, Ryan, Christy. Go ahead and give us a quick introduction. We want to hear from you all. Take a few minutes to describe your role and what innovative things your teams are doing to integrate food and health coaching into the culture of healthcare. And we can start, let's start with our guest, our new guest. Ryan, go ahead and get us started today, if you don't mind.
Sure. Thanks, Kofi, and thanks for having me today. So I'm the advisor for Spectrum Health Lifestyle Medicine, and a lot of people ask, what on earth is an advisor? What do they do? So I'm an extension of our medical director and director for this system. So I help lead the strategy, business development, reimbursement, analytics, and then portions of operations for the new specialty practice. So although my undergrad and graduate education has been focused on business, I've really spent the last 14 plus years of my career at two large Michigan health systems leading teams around strategy and innovations. I spent the last 2 years specifically in lifestyle medicine, building unique business cases and strategy for launching a new specialty practice that was dedicated to lifestyle medicine. So in January 2021, we did just that. We successfully launched our new specialty practice within a teaching kitchen. We offer a wide range of services, both virtually and in person, some of which are consults with providers, health coaches, RDs, as well as a variety of culinary medicine classes and shared medical appointments that integrate culinary medicine within the shared medical appointment. Some of the services we offer are cash-based, but most are actually reimbursed through insurance. And so we have an amazing team of physicians, health coaches, RDs, RNs, chefs, and then some non-clinical team members like myself. So yeah, happy to be here today. Thanks.
Thank you for that, Ryan. Christy, go ahead and give us your introduction.
Awesome. Thanks, Kofi. I just spoke to everyone about 20 minutes ago about DPP, but in addition to our DPP work, a lot of my work at the Y started and still consists of a heavy focus on culinary and nutrition education. So we have two teaching kitchens here in DC that I oversee the operations of. And one is within a Y, one's another community center. And we provide this mostly for SNAP eligible families across DC, Maryland, and Virginia. Additionally, we work with a local food hub to bring food to participants of all of our programs and try to encourage and also provide food to folks at our branches that are in lower income areas. And then additionally, as you know, we work closely with Children's Hospital here in DC, piloting a produce prescription program, leveraging the strengths of clinicians and of course, a place like the YMCA. And lastly, I serve on DC's Food Policy Council and I co-chair the Nutrition and Health Working Group. So hopefully, you know, we provide the education, but we know that more upstream is that advocacy. So try to dabble in all of those and hopefully the DC area healthier.
Excellent. Thank you for that, Christy. Abby, take us home.
All right. So you all heard, that I'm part of this great group at the Center of Excellence Primary Care, and we primarily do a lot of randomized control trials utilizing health coaches. So in addition to managing those studies, I'm also working as a patient community advisory board, oversee the for UCSF. So I work a lot with community engagement with our federally qualified health centers and community members. So in addition to also the research out of CEPC, we also do training of health coaches. So I know that there were some questions about that. So also I'm a trainer for health coaches out of our center. And then I was recently appointed to serve on San Francisco's Sugary Drinks Distributor Tax Advisory Committee. And so San Francisco is one of the major cities that has the sugary sweetened beverage tax. And the way that the mayor decided that the money will be allocated is they created an advisory board of 16 members. And so I serve on the research medical seat for a 2-year term. So yeah, all of that together with what you heard in the presentation, I'm excited for this panel. Thank you, Dr. Essel.
Awesome. All right, thank you for that, Abby. Okay, so let's go ahead and get started. It looks like you all want to go big from the beginning. So let's go ahead and ask one of the questions from David in the audience. So I think this is towards you, Ryan. So how do you integrate your lifestyle medicine program into your value-based contracts and payer arrangements?
It's a good question with creative answers, I think, is kind of how I'd start, I suppose. So we are very much in the balance between fee for service and value contracts. And so it actually makes it even a little bit more difficult at times, because going to payers at the end of 19 or end of 20, beginning of 2021, we're in full value contracts with two of our largest payers. So they out of the box don't necessarily want to engage in more risky or more risk contracts or more pilot studies. So we've actually focused on some of the fee for service models, and we are continuing to do that. We've had a lot of success with it, but we're in constant communication with those next value contracts. And so they're going to look a little bit different, I think. If you think about the historical pay for performance model, I think there's a lot of potential for insurance companies to engage with us in a pay for disease reversal or reduction, or cost of care reduction. So those are the kind of exploration conversations we're having right now. But for Spectrum Health, a lot of our stuff is actually still being reimbursed by fee for service. And then once we have the value that is seen from those patients, reduction in utilization, the Spectrum Health side will also see that.
Awesome. Christy or Abby, I have another question here. What are the codes that you all are using to bill for CCMS people who are doing education for patients in a clinical setting? Is that something you all are familiar with?
I can jump in on my end, because we're doing it through a randomized control trial, and it's an NHLBI study, the National Heart, Lung, Blood Institute. We are not necessarily doing that, but in terms of some of the billing, it's just if there's certain lab work that the patient is aware. So not specifically for health coaching that I can respond to, because it is a trial study.
Got it.
Yeah, and the only thing I can add for DPP, the reimbursement for Medicare, Medicaid DPP is based on an individual's attendance and their weight loss, depending on which session that they're in. And I don't know the codes offhand.
Ryan, could you add anything to that? Any sort of billing coding tricks of the trade that your team has been using?
Specific to health coaching?
Health coaching, yes, or in particular culinary medicine as a whole.
Yeah, so health coaching, the codes are all temp codes right now. And so what we are doing on that side is dropping the temp codes into our chart. That way we have this trail of documentation that flows in from both our side as well as the payer side. And what that'll allow us to do long term is to prove that health coaching is a substantial intervention that can help folks make lifestyle changes. And so we're kind of playing the long game in a way. So that's what we're doing with health coaching. We're not getting reimbursed for that. But I should also say that on our, we do the CHIP program, the Complete Health Improvement program, and we have combined CHIP or health coaching within CHIP, and we're not being reimbursed for that either right now, but we're collecting a ton of data around it. And so some of our interventions we can get reimbursed for, and it kind of covers some of the costs of doing health coaching until we can get that full reimbursement.
Excellent. Okay, so there's this issue that keeps coming up with billing and coding and how we're going to get paid for this work that we're doing. I think we need to explore that a little bit more. So how do we sort of build the argument for our funders, for private, for industry, for insurers? How do we sort of build that argument a little bit better so we can move in that direction? Christy or Abby, you can start with that one.
I can say that, what I just spoke about in DPP is that it required a lot of research for us to prove that DPP works and then to get CMS to approve for Medicare reimbursement. I know that that was a YUSA project for probably 2010 to 2016. So it took quite a bit of time, and still it operates differently for Medicaid by state. So I think we just need to prove the outcomes, but it requires, like, I know that the Y was able to get that and to get on the radar of NIH and CDC because of the scale that the Y has, but it took a really long time to do it.
And our approach is really from the data and evidence. So as I presented earlier and what we are continuing to do, so really continuing to build that evidence base and then turn it into a policy and advocacy change, especially for private insurers. But the perspective that I come from is really continuing to build that data and evidence.
Ryan, can you expand upon that? And also, can you describe a little bit more about the temp code? What is meant by a temp code?
Yeah, so a temp code is a code that has been approved for use. So like Medicare and Medicaid recognizes this code. They usually have a T at the end of them. And they can be utilized, but they are not going to be reimbursed. And the whole idea behind it is for data collection, frankly. And so there are some cases, that folks are using that, similar to us, where we want to drop those codes frequently and track the outcomes that occur as a result of them. So do you want me to hit on the data to that? Yeah. Okay. Well, normally I would say like data is the new bacon, but with this group, I'm going to go with data is the new kale. And that's really, like Deming said too, in God we trust. Everybody else bring data, and so that's exactly how we structured our space. We built our Epic department from the ground up, and it gave us an opportunity to kind of start from scratch. So the way we built how physicians engage with patients, everything is a digital approach first. So our health risk assessment, our readiness assessments, our dietary assessments are all done virtually through the MyChart app that is baked right into Epic. So we use Care Companion, which is a different tool and a different story probably. But all of that data actually flows in for the provider so they can see like a synopsis view of how this patient's trending over time. But what it also does is it gives us the ability to abstract all that information very readily. So when we go to a payer and have that conversation, or you're going to your administration to say, we want to start a new program, you have all this data that just kind of helps you support the work that you're doing in improving those outcomes. We've only been up and running with our codes, utilizing the codes for about 6 months. So it's a little early to start showing the cost of care reduction, but that's where all of that value concept and contracts come into play. And we'll really leverage all this amazing work that everyone is doing.
Great. So what it sounds like is that we're early in this process and we still have a lot of learning to go before we can start really billing and coding successfully in different settings. You may have some strategies that work locally where you are with your local insurers, but sort of a national movement, we have some ways to go there. So that's very good to know. I have a question from the prior panel. Let me go ahead and throw it at Abby in particular. So the question was about coaching. So where do your lifestyle coaches get their training?
So we develop the training within CEPC. And so we train our coaches, and we also can train anybody from the clinic, so different clinical teams. So this can range from physicians to nurses to medical assistants, registered dietitians, community health workers. So we also do have the training available as well as the research that we are gathering for the evidence of it. And
because of your expertise, and Ryan, you can add on to this as well, what coaching programs would you describe as being reputable for others trying to do this kind of work and don't have sort of the resources you have at your site?
Self-promotion, but I would recommend our resource of the, if anybody is interested in looking into it, again at cepc.ucsf.edu. So what our co-founders have done have also, taken the different, some of the other coaching that they've seen from other clinics, but then created sort of our own approach. And so that is what we use in our research and our evidence.
And Ryan, do you all use a similar, what programs do you all use and what would you describe as being reputable?
Yeah, so we, really only use Well Coaches right now. So the Margaret Moore, that program. And so all of our health coaches are certified through that program. And then we have some that have additional certifications around tobacco, nicotine treatment and things like that. But yeah, all of them are Well Coach certified.
Got it. One provider asked, as providers, do we have to have an official health coaching certification to market ourselves as such in a clinical setting?
Technically no, but it seems like a good idea to have some type of certification.
Excellent. Let me bring in Christy really quickly. So a lot of people have been wanting to know more about the DPP program, and specifically for the pediatric age. A lot of our attendees are working with younger kids. Is that something you all are looking into? The question in particular was, are there any future plans to extend the DPP program to the pediatric age group?
It's a great question. I don't know if YUSA is developing a program specifically for pediatrics, but we do have a program called Healthy Weight in Your Child that it targets childhood obesity. So we probably won't develop a DPP program for kids because it would just be similar to Healthy Weight in Your Child.
Got it. Okay. And another person was asking specifically about the YMCA. They said, what can be done to bring the YMCA into a community in need?
Oh, love that question. I would say there's two things. So usually when a Y is being developed, a lot of the funding comes from local government. So if I would advocate for it with your local government, but also there's a Y in every state, and so some of the associations spread across a huge geographic range. So I would reach out to someone who's in your state and say, hi, I'd love to learn like if the Y is going to come here, because most Ys are actually not building new branches. We're doing a Y without walls model. So we're either in childcare sites, in hospitals, in schools. So they don't necessarily have to have a building, but they can certainly come to your community. So I would reach out to one in your state, but if you want an actual building, I'd say probably advocate for it.
Love it, love it. Christy and Abby, I'm looking for questions. Christy and Abby, question here was, what are some of the other strategies that can be used that health professionals can use to influence dietary change on the individual, community, and or policy level? Can you all speak to that?
Yeah, I can jump in first. One thing that I spoke of in my introduction is that I'm part of the Sugary Tax Advisory Committee, and more and more larger cities are starting to pass this tax. And so in your role as either a clinician or just an advocate for your patients, I would suggest that you advocate for this tax in your city, and the tax money that comes from the sugar sweetened beverages goes back into the community for chronic disease prevention. So, in a lot of cities are pushing it. I know DC, that's something also on the table, but some of your other smaller counties might be looking into this, and that's something that I would encourage.
I would just echo what Abby said. We on the Food Policy Council, we do have one physician, and it makes a big difference to not have someone who works in a nonprofit setting, because nonprofits are always asking for money. So like advocating, getting a diverse voice that's not like seeking out funding for their own programs, it carries a lot of weight. So I would just say advocate, get involved in your local council. It's likely that if you're in a big city, you have a food policy council, and most of these councils are moving more towards this health and nutrition space.
Thank you for that, Christy. Ryan, I got another question that came in for you. What are so they were asking about funding strategies. So funding strategies in particular for these kind of interventions have often been quite challenging. What are some novel ways that your teams have used to build an infrastructure to fund these initiatives? How have you all built an infrastructure around this?
Sure. So we started with 2 grants around culinary medicine. So one for Family Kitchen RX, and that program is bringing families into our teaching kitchen. And then the other was a change study that was in collaboration with the Spectrum Health Cardiovascular Center. So that's kind of how culinary medicine started for us at Spectrum, but it really launched that starting point for conversations around the specialty practice, lifestyle medicine specialty department. And so from there, it's started with system leadership, getting buy-in. We've created a really robust, what I call the guiding coalition, and it's like coding, clinical compliance, billing, revenue cycle. And it's key people from those areas. And why that's important is when you start using those billing codes to have people that have your back if you were to start getting questions around the use of some of these codes. So what we had found that there was no other specialty practice specific to lifestyle medicine. So when you started dropping those codes for payers, everyone was just like, what is going on? What is this practice? Who are these providers? So to have, that guiding coalition behind you to help answer the questions. And we actually, we went in knowing what codes we wanted to use, but we actually posed to that group of leaders and basically said, here's what we're trying to do. Help us figure out the right code to use. And that's kind of where we started. And then we actually have monthly meetings where we review denials and trends and different documentation issues. And I think that's really important. We learn a lot from getting a denial, or, when a payer comes back and say you didn't, document, specificity for this obesity code and things like that. It is definitely a journey or a voyage, but it's worth the fight.
Thank you for that. Christy, can you add anything to that? Have you all built any sort of innovative strategies around sort of building a good infrastructure for funding these things?
Mm-hmm. Yeah, similar to what Brian said, we definitely rely on a few grants, especially in the beginning of a new program. But really, our North Star is direct payer agreements with an MCO, because oftentimes they have funds specifically for prevention programs. So we, once an MOU is finalized, they give us a list of members who qualify for a program, we enroll them, and then they reimburse us for the cost of the program. That's kind of a best case scenario. And then of course, eventually when we bill for something like TPP with private insurance, that's also great. So moving more from grants to the payer or insurance reimbursement.
Thank you for that, Christy. Abby, looks like somebody wants to add on. What are some other strategies your team has implemented to create a funding stream for your integrative work?
Yeah, again, so mostly through grants, but what the clinics that we work with are federally qualified health centers. And so we work with underinsured to low insured patients. And, this just continues to build the case. And so when we're working with these clinics, we started with about 2 clinics, and now we're working with 10. And so, when we're talking about specific funding mechanism in terms of like that reimbursement, it doesn't necessarily apply. However, we are also helping patients get back on track with their annual PCP visits or staying in touch with their PCP. And so through the different insurances, usually they are, because we're California, it's Medi-Cal, and some are Medicare, but they're able to stay on track with their insurance, because our health coaches have also helped some stay on their insurance and help them navigate that system. So a little bit off of the question that you're asking, it's more of, the way that we're keeping patients in care with their insurance, and that insurance being used to see their physicians or their primary care providers is one way that I'd like to respond to that. Not necessarily that it's a program, because we're doing a lot of the research still.
And my assumption is a lot of the care that you all have been providing has been more using group visits as a strategy versus trying to go more with the one-on-one. Is that, I think, Ryan, you all do mostly group visits for this kind of work. Is that correct?
Yeah, we really try to do more shared medical appointment, group visit. Yeah, absolutely. I think there's a lot of reasons to go that route, and we've actually found awesome patient engagement with the group visits. Patients love it, and they actually keep wanting to come back and engage in other ways. And there are codes out there that support group visits.
When you all do the, yep, go ahead.
I was going to say, we do the one-on-one currently. But it's I guess I just want to emphasize also that the health coaches are not in replacement of a clinician, right? That I just kind of want to emphasize that again, that they're in support of the clinician, and they're part of the team. And so they are not doing any diagnosing, they are not doing any types of recommendations that don't involve the clinician. So that's just something else I want to emphasize.
Someone asked in particular about your coaches. How did you recruit these community coaches, and are they all volunteers?
So for us at UCSF, they are paid through the Center of Excellence Primary Care. Some have applied specifically when we put out job postings for health coaches. Some have been recruited because they went through our training, and then let us know that they were interested if we ever had any available positions for health coaches.
Got it. Actually, let me expand upon that. I think I saw a question earlier. I'm going to go to this, and then Ryan, I'm going to come back to you about a group visit question about billing and coding. Do any of your groups work with community health centers, and I read that wrong. I was reading community health workers, but it's actually community health centers. So anybody working with community health centers or FQHCs, but Abby in particular, you mentioned you do. Ryan or Christy, are you all working with any community health centers or FQHCs?
Currently, not formally.
Okay.
Yeah, I'd say not to like that type of capacity. We certainly have relationships and rely on community partners.
Excellent.
Yeah.
And then Ryan, expand upon this last question. Somebody asked in particular about the group visits. What are some of the common group visit codes, whether temp codes or not, that your group typically uses? And I also want to hear a little bit about who makes up the team. So when you all have these visits and you have the team members who join you, is it a clinician? Is it who's part of the team when you're all having these visits?
Yeah, so it's definitely it's been a journey, and we started heavier on the front end. So when we started these group visits, we had and they were all done virtually because of COVID. So keep that in mind too. So we had to have a moderator as well as someone to help the physician document, and then you have to have the physician and then potentially an RD or a chef, because we're pulling in culinary medicine for some of these shared medical appointments too. So some of them had like up to 5 people in a group visit, but traditionally it would be 2. It would be a person documenting with the physician who is leading the shared medical appointment. So that's kind of the staffing behind it. So we're anywhere in between 2 and 5 right now, depending on how involved the class is. But we do have chefs come in, which is great. For coding, we primarily actually use E&M codes for most of the shared medical appointments. We have done a lot of work around preventative codes. So there's codes out there for group visit that's preventative. We've personally had some issues with our local payers where they don't want to do virtual preventative. So we can bring people in and we can do that in the space. But with COVID, our health system prevented us from having groups of people, obviously. So we weren't able to use those. So I'm kind of excited that we're opening back up to where maybe we could leverage some of those other codes. But we kind of hit capacity pretty quick, even with new patients. Typically, a patient would come in, they would have a one-on-one with a provider where we do some biometrics and have a really good conversation about their health risk assessment and their readiness. But we hit capacity with the providers we had. So we ended up launching a new one called New Patient SMA, where we bring them in and it's a group patients for their first visit and interaction with lifestyle medicine. And that's also an E&M. And so I saw a question in there about timing. And we have, a code helper in Epic that kind of helps the physician around time versus coding based on, acuity of the patient. And that will vary, but with shared medical appointments, you can't bill for all of them at the same time. So it's actually better to individualize it and talk about time spent with each individual patient, specific questions they asked. And that's where the digital first kind of approach helped out, is because when a patient messages through the MyChart, it actually will go right into that shared medical appointment to where the physician can reference that question, then it ties nicely to the group appointment. And then it helps with billing and coding on the back end too.
Excellent. Christy, I got one here about the why and DPP. What are your thoughts on, and this is controversial, but it's about weight and weight loss. What are your thoughts on the heavy emphasis on weight and weight loss for DPP participants? In their practice, they found that a focus on habits is more helpful. Patients can improve metabolically without a significant change in weight. Although we understand the correlation with weight, we have seen that that an emphasis on weight can create problems more than it solves problems. So can you speak about that a bit?
This is such a good question. Whoever that is, I could talk to you for hours about that. Thank you for raising it. It's something that we think a lot about, especially with our nutrition and culinary education. And we probably like 2 years ago had just a lot of pushback about like what our role is and what really the goal of our programs are. So I can speak for, our culinary and nutrition work. We definitely learned to focus more on skills and self-efficacy. And that's what we evaluate for those programs, because those classes are not taught by dietitians. And so it just didn't feel appropriate to ever bring in weight. And yes, I agree that it's something that we know a lot about in terms of correlation, but stigma is difficult, and it's something that I think as a culture, we just have a lot of work to do. But in terms of DPP, I will say that, so we're measured on our outcomes, and truthfully, that's really how we get paid. It's usually through the amount of weight that's lost and a participant's physical activity. However, during the sessions, we don't really talk about weight. More often than not, we're just having conversation about how an individual did this past week, what sort of behaviors that they did, did they write in their new food log, or did they look at the nutrition facts label? So we do focus heavily on behaviors, and really a lot of DPP is pretty conversational among the participants. So weight isn't really the focus. It's just unfortunately how we get reimbursed.
Got it. Abby and Ryan, I'm going to focus these next ones on you. So Abby, some questions came in about the difference between MI and health coaching. Can you speak a bit about the differences that you see there?
Yeah, there's a lot of similarities. So MI focuses on like active listening and a lot of these other open-ended questions, and a lot of reflective statements. But then health coaching takes it a little bit of that step further to also really help with initiating the action and keeping that accountability with the patient. So it works with the skills of MI, and it incorporates it with just a little bit more enhancement of this health coaching to take into that action. And it's a continuation. So sometimes the motivational interviewing is in that one session of that, that one particular maybe interaction that you're having with the patient. And then the clinic visit is over and that's it. But with health coaching, it really continues. So it's really that continual spectrum of the patient and their end goal.
And can you speak about the opportunity for virtual health coaching? Is that a thing? Can you complete health coaching virtually?
Yeah, so similar to what Ryan said, a lot of what we had to do in COVID was adapt to something virtual. And to what I can speak to in the last year, it has been successful. Some of it over Zoom, some of it over the telephone. And it's also been helpful for some patients who just have barriers to transportation or barriers to, for themselves, maybe an inability to get to a certain location, whether it's like childcare or, what have you. And so it's just really given an opportunity for a lot more access. And we've even used health coaching skills to help people log into Zoom. So, non-clinical ways that we've also used health coaching to help patients. And then that's helped them to also adapt to telehealth visits with their primary care physicians.
Ryan, I'm going to point this next one to you. So there's a great question here about the role of RDs and health coaches. So you mentioned having RDs as part of your team, and there's a individual here, looks like they're a dietitian, and they mentioned how the role of a dietitian and a health coach seems to overlap in some ways, and there's some fear or worry that the health coaching role may be treading into their water a bit. And so the question is, can you all distinguish the roles of a health coach versus a dietitian in the work that you all are doing?
Yeah, so I would lean on the actual codes too. So dietitians, what they document, the work they're doing is really specific. So we do drop registered dietitian codes, MNT, and so we utilize those every week. We've had hundreds of those appointments since the beginning of the year, and they are different than health coaching. So our RD is health coach, well coach certified. So she is a health coach, but the focus in what she documents and has, talks about during those conversations, dietitian versus health coaching, are different. And there is a line there. I know that there are some things that overlap, but what the dietitian brings to those conversations is different. And so it's an important line that we're going to have to kind of flirt with along the way. I mean, to be completely honest, because I think it's important to keep them separate, not just for reimbursement purposes, but for what the dietitian brings to the clinical side of our department.
And Abby, can you expand on?
Yeah, for us, for our health coaches. So again, there's a very specific distinction. And so our health coaches are in support of our clinicians. So whether it's the registered dietitian, a specialist, a nurse practitioner, or a primary care physician. So any of the action that the health coach takes that's directing a patient to do anything health related comes from the clinician. So the health coach won't act on giving advice or recommendations without that specific recommendation. And we also use Epic. And so all our communication is through Epic, and it's all documented that way. So we use all the features of Epic and MyChart as well to communicate between the patient and the clinician, and so that everything is recorded in the patient's chart. So again, the health coach is really there to support the direct recommendations that are given by the clinician. So if the RD is saying we would really like for the patient to increase this or decrease that, then the health coach can take it upon themselves to work in those skills that I shared earlier on how that patient can achieve it, report back to the RD or work in tandem with the RD or the nurse, nurse specialist, nurse practitioner, or what have you. So again, it's really that team-based approach in collaboration, not in lieu of.
Thank you for that. Christy, question for you. How do we stay sensitive, and how does your team stay sensitive in particular to understanding the sociocultural context when implementing these strategies that you all are using?
That's also a great question. One of my biggest learning curves, so I've been with the Y for 9 years, and one of my biggest learning experiences was like my second year in, and I was running a training for our childcare staff about healthy role modeling. And I had brought someone in to run the training who's a good friend of mine and who frankly can relate to our childcare staff and is from DC, just has more of a lived experience. And honestly, he got across in 30 minutes what I had been trying to do for 2 years. And like, it was that moment where I was like, I can't be this person. Like, I can't be the face of a lot of this work anymore. And I think I definitely have an advantage of working for a huge organization that has a recognized brand, and I can kind of hide behind that in our programs. But, we've really had to reevaluate who our teachers are, how they can relate to our communities, and if they should be the appropriate faces of the Y in certain communities. Additionally, we are constantly asking for feedback of our programs, and we work really hard to implement the feedback that we get so that folks know that we're actually listening and adjusting. But I think my team, we operate with the motto of change moves at the pace of trust, and relationship building is just really important for us. Like, we always have the same instructor. That person is dedicated to a specific location so that there's just like a lot of consistency. Folks know who to go to, and it's a trusted face within whatever community that they're in.
Thank you for that. Abby, it looks like a question for you. So recognizing that in doing this work, working with more marginalized populations, a lot of tough things come up, a lot of trauma comes up. Health coaching sounds like you can use it for a variety of unique things. In particular, you said, how do you use and activate the Zoom function, right? So how do you all use health coaching in particular, it looks like, to retrieve some of this sensitive information about what's going on with your family to be able to create more a tailored support for your families?
Yeah, that's a really great question. And so like I mentioned, because we are working with all of our patients who come from federally qualified health centers, there's a lot of trauma in the communities that we work with. So our health coaches are also bilingual, so that we can work with our Spanish speaking patients. But similar to like Christy said, trust is key. And so our health coaches, first and foremost, are there to just listen. Depending on how the session is going, sometimes it's just the health coach that's listening the entire time. And of course, as the sensitive questions may be coming up, depending on the patient, sometimes they've been opening up, but we also want to assess for behavioral health in that moment. And so because if it's a visit that's related to something with chronic disease or anything like that, but first and foremost is we want to address what's happening with the behavioral health issue. We put that on pause and address that with the patient. So health coaching has allowed us to really open the door to like the whole patient. We're approaching it of what we want to do to help with their chronic disease management, but beyond that, it's who this patient is as a whole, and health coaching has allowed us to approach that and to really build that trust. And a lot with our open-ended questions and active listening and empathy and appreciation, it's really allowed for a lot of that trust. And so sometimes addressing some of those other issues has opened the door to then move on into the chronic disease management. But just also hiring health coaches from communities and so that they can work with patients that look like them, being bilingual. So a lot of times a lot of institutions have said that, but we are trying to really act on that to make sure that our health coaches reflect the community.